Hello, I'm Dr. Richard Krasuski from Duke University Medical Center. I'm here with my esteemed colleagues, Dr. Paul Forfia from Temple University Medical Center and Dr. Rajan Sagar from UCLA Medical Center. Today we're going to tackle a difficult topic, a challenging topic, that of the patient with advanced pulmonary arterial hypertension who is acutely ill in the ICU setting. I'd like to start, Paul, with a question about medical therapy. So at what point do you feel we've actually reached a point that we're saying medical therapy has failed and it's time to move on?
That's a good question. I mean, I think we have to take a step back and say what is maximum medical therapy in pulmonary arterial hypertension? And maximum medical therapy in pulmonary arterial hypertension would include 2 oral background therapies and a prostanoid therapy. And at maximal level therapy, the prostanoid should be parenteral, whether it's continuous subcutaneous infusion or continuous IV infusion. So to me, maximized medical therapy is that you're on 2 oral drugs in the background and you're on a parenteral prostacyclin. And if a patient is not on a parenteral prostacyclin and they are being characterized as having relatively end-stage pulmonary arterial hypertension, that's a miscalculation. That's a type of patient that would have to be started and titrated on a parenteral prostanoid and see what the patient's response is to that prostanoid. Because what we often find is you can resurrect a patient like that by putting them on the appropriate medical therapy and adjusting it over even a few weeks or a couple of months.
Such an important point. I think, when you look at the REVEAL registry and realize that approximately half the group dies without being placed on an IV prostacyclin, it's pathetic, right? I mean, we should be really thinking about how can we advance that therapy. So, okay, Rajan, we've maximized our medical therapy. Unfortunately, the patient just isn't turning the corner. How do we approach that patient? When do we start thinking about things like transplantation or mechanical support or even extracorporeal support?
Yeah, I mean, if we take a step back and kind of take PAH, look at it sort of in a more globally, I think we can all appreciate, and we have an incurable progressive disease. So, when I see a patient, especially with high-risk features from the get-go, or if they're evolving in such a fashion as I follow them over time, I think we all should be thinking about, what's the next step after failure of maximal medical therapy, well before you've actually failed maximal medical therapy, and the discussion about, options after failure of medical therapy, including, lung transplantation, which is really the primary consideration, really should be discussed with these patients sooner than later, not necessarily to scare patients, but to help them understand and make sure we always remember that there are a group of patients which can be going there and will go there, and sometimes quite fast. So I think that discussion should be had early, and I think what also comes up is how we can bridge these patients, for instance, in this ICU setting, in the advanced right heart failure patient with PAH on maximal medical therapy, what we do with that patient. If there's nothing left to offer medically, hopefully that lung transplant discussion has been had. Sometimes they're already actively listed and they're waiting, and they can continue to do so on vasoactive agents in an ICU setting, mobile, and sort of in the hospital waiting for transplantation. And sometimes we're stuck with the scenario where they actually are progressing despite all of that, and we have to consider bridging type mechanical circulatory support, usually in the form of some type of ECMO, extracorporeal membrane oxygenation type of support. And these patients usually, because of their pulmonary vascular disease, require a veno-arterial type of circuitry. And the discussion of that and how you cannulate such a patient, how you keep them functional, and how you keep them transplantable is a whole other discussion, I think.
So Paul, one of the things I heard Rajan say over and over again was bridging the patient. So bridging, we're obviously talking, those of us that manage a lot of folks with pulmonary hypertension, is bridging to transplant typically. What about bridging to recovery? What's your opinion of that? Does it happen very often? I mean, when these really acute, very acutely ill patients who, for instance, the patient who just hasn't been seen and presents with advanced disease, I hear the bridging discussed, but sometimes that bridging is to nowhere. What is your thought?
Yeah, this is a very challenging area. So say a patient has markedly delayed diagnosis and they initially present to you in a state of cardiogenic shock, where one is left with either little or no alternative but to place them on something like venous arterial ECMO, VA ECMO. The chances of you getting that person onto optimized PAH medical therapy and then decannulating them and getting them to a native spontaneous circulation is very low. So, and there are many reasons for that. Once a person is cannulated and they're put on systemic level anticoagulation and we start to optimize therapy, we have tremendous problems with bleeding and platelet dysfunction. So we will try at almost any cost to avoid having to put a person on ECMO when they do not have an immediate bridge destination like a transplant, because your odds of getting the person back off of ECMO are extremely remote.
Gentlemen, thank you so much for that astute discussion. We learned a lot. Obviously, can't forget about the importance of placing those patients on IV prostanoids when they're ill, and don't call it a failed medical therapy if we haven't given the medicines we've got available to us. And then think about some of those options we have to try to stabilize the patient, but also recognize that some of them we're just not going to get to. And if those particular patients end up on these bridging type therapies, it's a bridge to nowhere, unfortunately. So we got to make sure that we discuss transplant before we get to that point, ideally. Thank you, everybody, for your attention.